I think DKA we see with SGLT2 inhibitors probably is the second most common consult that I see in emergency. Since the drugs were launched approximately 7 years ago, we predicted that there's going to be more cases of DKA with these drugs. We know that, we have paper after paper about the benefits of these drugs. But if you look at it closely, actually, at the end of each paper, they talk about the adverse events with these drugs. And they usually undermine the importance of this one serious side or adverse effect of a SGLT2 inhibitor class, right? And what I see in explanation of DKA by all of these authors that, patients don't stop when they are sick, so they don't know how to manage sick days. It is true that some patients with DKA or SGLT2 inhibitors have underlying pneumonia, right? But I do see majority of the patients actually present primarily with DKA related to SGLT2 inhibitor. And there's something behind it that we have to explore as clinician as to why DKA happens. The second explanation that's always given is, oh, patients stop using their insulin. But it's a fact that I see majority of the patients with DKA on SGLT2 inhibitors, patients that are actually not on insulin, they were just on oral hypoglycemics, right? So to assume that insulin deficiency alone is the cause of DKA is also not right. So I thought it was important to go through the basics of DKA and then try to explore. There's some proposed mechanisms of how SGLT2 inhibitors can cause DKA. And I have to really stress the need to ask everybody that these patients are extremely sick. You can treat a DKA with type 1 diabetes within 12 hours and fix them, but many of these patients end up being in the ICU, and sometimes it takes 2 or 3 days. I have seen repeatedly that patients who are fixed with insulin drip switch to subcutaneous insulin, and within 24 hours, they drift back into DKA, likely from long duration of action of these drugs. So I did divide presentation into, 4 different subjects. It's important to know the pathophysiology of DKA. A lot of people don't know it. Everybody believes it's insulin deficiency alone, but it's not true, actually. Then we look at the natural progression of the disease, because as the disease progresses, patients are much higher risk for having adverse events from these drugs related to their hormonal changes from advanced type 2 diabetes. And then I'll explore some of the mechanisms behind DKA from SGLT2 inhibitors, and then try to identify our population, actually, which may be susceptible to these adverse events, and then possibly not put them on these class of drugs. So I always like to start with a case, and it's very important, actually. If I ask you a question and present a case and you have to answer, you will never forget the explanation for that question. So I have this very simple question. I made it up, actually. So you have this man who has pancreatectomy done for pancreatic mass, which was not really a cancer, and he was discharged home on insulin. And then 4 weeks later, he came into the emergency with the blood sugar of 75 millimoles because he stopped using his insulin, and his wife confirmed that, right? So without presenting any other data, would you expect this patient to be in DKA? Anybody? There's no right or wrong answer. If you believe that, yes, the patient is going to be in DKA, you can say so. Somebody should participate, actually. No? So is this patient presented with hyperglycemia is going to be in DKA, or you think he will be in DKA or not? Nobody? All right, so he's not going to be in DKA, even if he has severe hyperglycemia. And I'll explain that later on, because I think it's important for people to understand the mechanism behind DKA. So I have another question. So you have this patient who presented with DKA and he's on empagliflozin or Jardiance. And then you fix his DKA with 24 hours of insulin infusion. You switch this patient to subcutaneous insulin, and you give him dextrose to prevent any hypoglycemia because of the ongoing effect of these drugs. But patient went into DKA again after 24 hours while he is taking insulin, right? So what do you think is happening? Like why, the patient is on insulin, he was on DKA, you put him on subcutaneous insulin, and then he went into DKA again. It's a tough thing, actually, to be honest. I have to say that many specialists would not know the mechanism behind DKA because it doesn't really happen with plain insulin deficiency. And I'll present you the basics of DKA. I think it's very important, actually, for all of us to know exactly what causes DKA. So it's important to go to the basics. Human islets have almost 2/3 beta cells and approximately 1/3 alpha cells. So beta cells make insulin and alpha cells make glucagon, right? And the third cell, which is about less than 10%, is delta cells that make somatostatin. So many of these hormones or hormone functions of these cells are intertwined, which means there's an effect of beta cells producing insulin on alpha cells, and there's an effect of delta cells on both beta cells and alpha cells and their secretion. We call secretion stimulus coupling, right? Now, 50 years ago, and this is the basics of DKA, like we have to understand that insulin deficiency alone is not what causes DKA. It's hyperglucogonemia and insulin deficiency. So what they did was in New England Journal of Medicine 50 years ago, and at that time there was no good insulin. They were all NPH insulin, ultralant insulin. So they actually took around maybe 7 patients with type 1 diabetes. They brought him to the emergency with type 1 diabetes. And we know that type 1 diabetes they don't have any beta cells at all, right? So they have no insulin production at all. So they actually put half of those patients on octreotide drip, and then half were just washed closely. And both groups were washed very closely to see when they developed DKA. We know that octreotide we use in clinical settings when patients come in with sulfonylurea overdose because the delta cells within the pancreas would inhibit both glucagon and insulin. So what you're trying to do here is that in one group of patients with type 1 diabetes, where there's no insulin production, you have stopped exogenous insulin, and now you're giving octreotide to inhibit glucagon. And they see how patients develop DKA. It's real type 1 diabetics, right? So patients not treated with octreotide drip have endogenous glucagon production, and those patients went into DKA within 10 hours of their last insulin injection. And the patients on octreotide drip, where they were blocking glucagon production, after 18 hours of no insulin, those patients didn't go into DKA. So it's very important to understand that diabetic ketoacidosis happens only when you have insulin deficiency and you have hyperglucogonemia. Alone insulin deficiency would never cause DKA. And I'll give you an example. Many alcoholics, they come in, they have severe pancreatitis in the past, and they're extremely skinny. Their pancreas is destroyed. When they come into the emergency with hyperglycemia and they're not acutely ill or something, they don't have any DKA because it's not just their beta cells which are destroyed, but their alpha cells that are producing glucagon. Now, this is the mechanism behind DKA, and I think for everybody, this is the most relevant picture on this presentation. So I'll just point out towards that insulin deficiency causes lipolysis. So when somebody is deficient in insulin, you release free fatty acids from the fatty tissue. Glucagon also has lipolytic effect on the fatty tissue with the release of free fatty acids. Now, free fatty acids go through beta oxidation within the liver, and you produce acetyl-CoA. 2 molecules of acetyl-CoA combine through acetyl-CoA thiolase to make acetoacetyl-CoA, which is ultimately transported into liver mitochondria where ketone synthesis happens and combined with a third molecule of acetyl-CoA to produce HMG-CoA. Now, this is the precursors of ketone formation. This enzyme, HMG-CoA synthase, is tightly regulated by a protein called FOXA2 protein, which is stimulated by glucagon and which is inhibited by insulin, which means if you have a very high levels of glucagon, but you also have a very high levels of insulin, you can stop production of ketone bodies. And that's what happens when you treat DKA. The patient has very high levels of glucagon, but you're infusing a very high levels of insulin to inhibit FOXA2 protein. So the HMG-CoA synthase is inhibited. This is the rate limiting step in ketogenesis, right? On the other hand, people who are insulin deficient and they have high levels of glucagon, they have more ketone formation. And that's why I always say that whenever you see a thin patient, you suspect insulin deficiency, he's a type 2 diabetic, he likely has alpha cell dysfunction after 15, 20 years of diabetes. And these patients are at much higher risk for developing DKA from SGLT2 inhibitors. And you'll see many examples. Patients started on Jardiance 1 week ago, they presented the emergency with DKA without any concurrent illness. So this is the most important slide that you have to remember. Now, if you look at the natural progression of the type 2 diabetes, it's a progressive disease. Patients who have been diagnosed now will have a different hormonal sort of profile in about 10 years' time, right? We thought only, we have a single-minded thinking 10 years ago, 15 years ago, but if you remember, if you know Ralph DiFronzo, who's the father of diabetes, in 2009 in ADA session, he presented this Benting lecture, and he proposed, and everybody confirmed that there's 8 pathological mechanisms responsible for hyperglycemia in patients with type 2 diabetes. They call it ominous octet, or 8 different pathways. So all pathways are relevant. You can see here clearly. And every pathway has been supported by basic trials and clinical trials. They have shown that neuromuscular defects are there, kidney problems are there, muscle uptake of glucose is there, but they give number one to alpha cell dysfunction, which means as the disease progresses, your patients are making more and more unregulated glucagon. And second is beta cell dysfunction, which means as the disease progresses, you make less and less insulin, right? Now, if you look at the drugs, actually, and this is really important, actually, as a clinician, I like to know if my patient is on an SGLT2 inhibitor, what other drugs may help me prevent any DKA in future. And if you look at the drugs, actually, which drugs can inhibit alpha cell dysfunction? So you can look, number one, GLP-1 analogs. So Ozempic, Trulicity, Bydureon, whatever those are, Wegovy, and now Mounjaro, they have suppressive effect on alpha cells. DPP-4 inhibitors, if somebody's on Januvia, Tradjenta, or Onglyza, these medications act on number one, which is alpha cell dysfunction. Just remember, and I have a very good example. I have a patient who I have on Victoza and Forxiga, and he has some side effects from Victoza. He stopped his Victoza, and he ended up in DKA at North York General, right? So in clinical practice, we see these cases which, gives us direction as which way to proceed. So it's very important, actually, that you realize that hyperglucogonemia, not just insulin deficiency, can cause DKA. Your thin patients may be at much higher risk because they are insulin deficient, right? Now, the natural course of the disease is progressive. Like early on in type 2 diabetes, if you look at the post-meal glucagon levels, instead of suppressing glucagon, they have paradoxical glucagon response. This is very common. So a lot of patients say that, listen, I ate only 1 slice of bread and my sugars went up to really 15 or 16 after breakfast. This is what happens. Instead of suppressing their glucagon, they have paradoxical rise in their glucagon. And the effect of this paradoxical rise originates from this interaction between alpha and beta cells. And if you look at the progression of the disease, and this is time in years, maybe 15 years or so, You can see that as the disease progresses, at the time of diagnosis, you have declining beta cell function with decreased insulin production. At the time when you diagnose diabetes, you start to have higher glucagon production. And this continues in a very advanced type 2 diabetes. Now, if you look at the beta cells and alpha cell mass, again, at the time of diagnosis, you almost have half of your beta cell mass, and your alpha cell mass is almost double. And you can see as the disease progresses, you have worsening beta cell function and you have, worsening alpha cell dysfunction. So with time, you make less and less insulin and you make more and more glucagon, right? This is just to show you intra-islet regulation of these hormones. This is like a normal person, and it just gives you an idea that when you have high levels of glucose, it depolarizes beta cell membrane, right? So it activates ATP-sensitive potassium channels. Calcium goes into the cells. Insulin is released. There's a local effect of insulin on alpha cells to suppress glucagon. So endogenous or EGP glucose production, endogenous glucose production goes down when you have exogenous glucose intake, right? So this is a normal effect of insulin on alpha cells. Now, in type 2 diabetes, when you have hyperglycemia, you're not producing enough insulin, right? So this suppressive effect on glucagon is lost. So ultimately, you result in high levels of glucagon, which further promotes hyperglycemia. Now, this is the proposed mechanism, and I'll show you some studies. They are small studies, actually, and because, nobody funds to look into the adverse effect of a drug. All these studies are published at university centers where they have maybe, 18 or 20 patients. Somebody's inquisitive, and they do these clinical trials and, in vitro studies on human islets. And I'll show you a few studies just to show you how these SGLT2 inhibitors affect glucagon and insulin. But the proposed mechanism is two-pronged. First of all, these drugs cause like significant polyuria from glycosuria. So higher the sugars are, the more polyuria you will have, because you will set a renal threshold really low. And that's why when patients are really severe hyperglycemic, it's not a good idea to put them on SGLT2 inhibitors because they're likely going to be severely dehydrated, right? So when you have glycosuria, you have normal glucose, right? Now, nobody knows how SGLT2 inhibitors lower insulin, but the proposed mechanism right now is mediated through lowering blood sugars. For example, if you have a 15 millimole, if your sugars are 15 millimoles, you have some stimulus on the residual beta cells to produce insulin. But if you drop those sugars with glycosuria, then the stimulus is less, so you produce less insulin. The effect of less insulin within the islets is lack of suppression of glucagon. So the levels within the islets of glucagon go up. So SGLT2 inhibitors lower insulin from lowering glucose, and lowering insulin will have an effect on glucagon. A number of studies now show that SGLT2 inhibitors actually has a direct effect on alpha cells producing more glucagon, right? Now this, on top of is somebody getting sick with surgery, infection, decreased oral intake. And I have to say that patients who follow keto diet, and I've seen patients with keto diet on SGLT2 inhibitors who present with ketoacidosis related to these drugs, right? This further causes lipolysis because many other hormones, including catecholamines, causes lipolysis. And again, the same pathway I showed you, that the liver picks up free fatty acids, it goes through beta oxidation, produces acetoacetyl-CoA, and the same pathway goes along, right? So you produce more ketones, and you end up having a DKA. This is the proposed mechanism. Now, there's a number of studies done. Smaller studies are done with dapagliflozin published many years ago, and this study was published in 2016. And the reason dapagliflozin was used because this is the oldest SGLT2 inhibitor. They started studying this in late 90s, and then there was high risk of bladder cancer, so they have to stop, they have to go back and then prove it's not an issue, right? So this study was done in type 2 diabetics. They picked 9, 10 patients, right? And then they, um, 9, 10 patients to placebo group, 9, 10 patients to dapagliflozin. And what they did was after 2 weeks of treatment, they did clamp studies looking at the hormonal levels as what happens to insulin and what happens to glucagon, right? And you can see clearly that this is a baseline insulin levels. This is micro units. We use picomoles here. In baseline insulin levels in baseline after 2 weeks of placebo, similar, right? But baseline insulin levels and after 2 weeks with dapagliflozin, the insulin levels drop in half, right? And same thing, if you look at the glucagon levels, this is placebo, no change in glucagon levels. But if you look at the dapagliflozin, the glucagon levels really go high. So it's not that they are producing less insulin, they're producing more glucagon, right? There was a study done with empagliflozin or Jardiance also. They look at how Jardiance would affect the glucose, the insulin levels, and insulin to glucagon ratio. And it somewhat showed similar effects in normal humans. And you can see clearly that this is area under the curve, insulin, area under the curve, glucagon, and then insulin to glucagon ratio in patients who have been treated with Jardiance. So you can see here, after 1 dose of Jardiance, and this is chronic, which means after 4 weeks of treatment with Jardiance, they measured all of these parameters. So what they checked was they checked the glucose in patients with at baseline after 1 dose of Jardiance, right? And then after 4 weeks of treatment with empagliflozin or Jardiance, right? They look at area under the curve of insulin, and you can see clearly that, acutely the insulin was reduced a little bit, but chronic treatment with empagliflozin or Jardiance resulted in significantly lower levels of insulin area under the curve. Similarly, if you look at the glucagon levels at baseline and with acute treatment with empagliflozin and chronic treatment with empagliflozin, and then this is insulin to glucagon ratio. It's like less insulin and more glucagon, right? So you can see your ratio actually changes from 35 acutely down to 28. So patients are actually making less insulin and they're making more glucagon. The most important actually was study published in Nature in 2015. What they did was they have human donors actually of pancreatic islets, and they actually looked at the effect of again dapagliflozin on glucagon messenger RNA expression, um, and the release of glucagon and the ratios. And I think I will just, it's a very busy slide, and I'll go slow so you understand. So what they did was they cultured these human islets, which have both alpha and beta cells from human cadavers, right? And then they measured what happens to glucagon gene expression when you treat them with dapagliflozin, right? Or in a normal glucose with higher value. So here's the normal glucose, 5 millimoles, and there's glucagon gene expression. And you can see that when you increase the concentration of glucose, the gene expression in patients, in normal people, are not exposed to dapagliflozin goes up, which means if you expose alpha cells to higher glucose, they tend to produce more glucagon, right? But then similarly, they measured the gene expression of glucagon in these cells after exposure to dapagliflozin. And this is, you can see clearly here that at 5 millimoles of glucose, the gene expression was almost double than somebody not exposed to dapagliflozin. So which means even if you have sugars at the same value, dapagliflozin or Forxiga would result in very high levels of glucagon gene expression. And when you increase the glucose in the bath to 15 millimoles, it goes up 3 times more. So higher the sugars are, the more glucagon gene expression you will have with these agents, right? Now, then they measure the glucagon secretion from these cells. And again, it just show you that at glucose of 15 millimoles, 6 millimoles, and 1 millimole. So you look at the normal person or a normal islet not exposed to any SGLT2 inhibitor, and look at the glucagon secretion at 15 millimoles, at 6 millimoles, and at 1 millimole of blood sugar. Is expected that the person or the islet would not consider 6 millimoles as hypoglycemia to increase the glucagon production. In fact, at 1 millimole in the bath, those alpha cells will make a lot more glucagon, thinking that there's hypoglycemia. When you reproduce this effect after exposure to dapagliflozin, you can see the glucagon secretion is exponentially much higher. So you can see here, this is at normal glucose values, and a patient is taking dapagliflozin. You can imagine their glucagon levels are going to be doubled. So it's very simple. That's why we call it euglycemic decay. So if a patient started his Forxiga, right, and their sugars are not too high, and they are advanced in their type 2 diabetes, and their sugars are normal, not high, they will go into DKA because their endogenous production of glucagon likely will go much higher, right? Even in the presence of euglycemic state. Then they look at the local effect of insulin release from the same islet and how it affected the glucagon production or glucagon secretion by these cells that were exposed to dapagliflozin. And I'll go through the slide very slowly. You can see here, there's a constant same concentration of glucose those islets were kept at. So then the cells were exposed to dapagliflozin, and you can see dapagliflozin, you can see the amount of glucagon production with the dapagliflozin was much higher, right? And then they expose the same islets to tolbutamide, which is a sulfonylurea, which will result in local release of insulin, right? So when you locally release some insulin, it has an inhibition effect on alpha cells producing less glucagon. And when you increase the concentration of tolbutamide further, the locally released insulin secretion is going to be much higher, which will further inhibit glucagon secretion, right? And at the end, you can see here, it's the ratios. I don't know why I'm in the picture. You can see here at the same glucose levels, and this is your glucagon and insulin levels. So glucose 6 millimoles in both cases. This islet exposed to, not exposed to dapagliflozin. This is exposed to dapagliflozin. And you can see clearly the glucagon levels do go up, even in the presence of normal glucose. And you can see that the insulin production comes down. So nobody knows why. You're trying to keep your sugars at the same level. It's not that you're trying to, inhibit insulin secretion because your sugar levels are low, but somehow there could be a direct effect of these cells, these medications on beta cells producing less insulin, right? So it's very, very simple, actually. I mean, I think for internal medicine, it's very important that DKA is triggered not just by low or absence of insulin, but you need an intact alpha cells or high levels of glucagon to cause DKA. Type 2 diabetes, again, is a progressive disease. There's progressive loss of loss of beta cells and progressive alpha cell dysfunction, which results in high levels of glucagon. This ratio of low insulin and high levels of glucagon is what drives ketosis in these patients. And then, as the disease progresses, as the disease advances, you have much higher risk, right? So I come up with this little thing that, I ask a patient each time a diabetic, long-standing diabetic comes to me, I always ask a question, are you losing weight, right? For example, when people want to lose weight, they follow low-carb diet, right? Or people don't realize the only fat-storing hormone in your body is insulin, right? Induces LPL and then you store fat. That's why type 1 diabetics are never obese, right? Advanced type 2 diabetics, when they have progressive loss in their insulin production, they started to lose weight. That's when I try to back off on metformin and any other drugs that may be putting them at high risk for, you know, um, ketosis from these drugs, right? And then you have to also see that, like your patients, right? I mean, it doesn't matter the age. Like sometimes you see a patient who may progress from being just on one oral hypoglycemic at the time of diagnosis to requiring insulin within 5 years. The rate of progression of the disease is different in everybody, right? And that is the reason that I always say that if you ask me, if I, as a clinician, just take two things to consider a patient to be on an SGLT2 inhibitor, like type 2 diabetes and heart disease, and I'm not looking at anything else, then I'm really not doing them any favor, right? And I always tell them, listen, these studies, you have to be very critical when you look at it. As a clinician, you're trying to do, first you do no harm and then you do good, right? And I give you an example. If you look at the EMPA-REG trial, and I'll just take one example of benefit of the drug in the trial was, say, for example, 38% relative risk reduction in CV death, right? So it's a very common number that we present. Say everybody say, oh, 38% risk reduction, right? When you look at the number of patients were there in the trial, so the absolute risk was 5.8% over a period of 3.1 years in patients not exposed to empagliflozin, right? And 3.7% risk of CV death in patients exposed to empagliflozin, right? If you look at the yearly benefit, the yearly CV death rate was 1.9% in patients not exposed to EMPA, right? And then 1.2% exposed to EMPA, right? So this is your 38% relative risk reduction in CV death. Now, take an example of the patients you have in those trials, right? Average age is 55, right? So, okay, you say, okay, my patient is going to live maybe 20, 25 more years. This benefit will accumulate over the next 20 years, right? You say, okay, he's also going to have less side effects from the drug, so he's a good candidate, right? I'm going to put him on. But if you have this 75-year-old patient, who are, and those patients are much higher risk for developing volume-related adverse events from these drugs, you're not doing them a favor, right? Because your absolute risk of death is not that high to justify the side effects or the issues you may have with these drugs. And if you look at the Canvas trial, there was a clear high risk of volume-related adverse events in elderly 75 or more, right? So that's why you have to pick your patients right. In my opinion, SGLT2 inhibitors are very beneficial class of drugs, right? But if I'm putting everybody with type 2 diabetes and heart disease on it, then I'm not, thinking from my brain, right? Because every patient is completely different. You have, like different types of diabetics, right? There's no two patients who are the same. And that's why we see time after time DKA in the hospital. Now, in terms of first case, which I presented, that patient has total pancreatectomy. And that patient will never come into DKA. He will have severe hyperglycemia and hyperosmolar state. He may die, but he will never go into DKA because he has no glucagon. And the second case that I presented with SGLT2 inhibitors, again, the pathological mechanism behind SGLT2 inhibitors is not that your patient stopped using insulin, right? It's the ratio that changes. There's high levels of glucagon production when SGLT2 inhibitors are used, and considering the half-life of drug to be around 12 hours, right? Like empagliflozin, it stays in your system for 60 hours. And I've seen many cases that, and actually I have learned it too, that there's a patient with DKA comes into the emergency on SGLT2 inhibitor, gap is 30, extremely dehydrated because they don't not only get dehydration from DKA, but also SGLT2 inhibitor, right? You fix them, the gap closes, you keep dextrose on, so you switch them to subcutaneous insulin based on their insulin drip rate, and the next morning their gap is elevated again, right? It's simply because there's an ongoing effect on glucagon with these drugs because I'm replacing insulin, right? So I fix their DKA, put them on insulin, but they still go into DKA again. So I have to give intravenous insulin, more intravenous insulin to correct it, right? So I'll just stop here. You guys should ask questions because I like more discussion, right? Anybody has any? Christine?
So,
Alexis, you...
Farooq, I can't find the raise your hand option on the phone that I'm using. So yeah, really interesting talk, and I think a good reframe in terms of thinking about the interplay of glucagon. Anecdotally, again, as an internist who does a lot of inpatient work, I see a lot of patients where sick day management is the issue, or where there is kind of another stress that's driving the DKA. You kind of mentioned like the patient who you start on an SGLT2 inhibitor and comes back a week later. I guess, what proportion of these patients declare themselves immediately? Does it happen further out, or does it tend to only happen when they have another intercurrent insult?
It's a very hard thing to predict, to be honest, right? I mean, I have seen patients within 1 week of starting SGLT2 inhibitor presenting with DKA. So I think, in my opinion, I think people who truly are insulin deficient, actually, they present early on with DKA because they don't have any reserves, right? So
Yeah.
they already have, maximal production of glucagon, and you just tip them over, right? So we see many times, actually. Last week, family doctor put me on this new diabetic drug, right? Everybody starts Yaris all the time, right? So to me, actually, I find that what in majority of the people, actually, the best indicator for somebody who may have problem with an SGLT2 inhibitor is being extremely thin diabetic, right? So, insulin deficiency is linked to being extremely thin. So to me, I think you have to be absolutely, uh, you know, clear about explaining to your patient who is extremely thin that, listen, if you don't feel well on these drugs, I'm going to put you on, which is good for your heart, whatever, right? Then you should have a low threshold of stopping it. I always tell patients, right? The drug is good for you, but if you don't feel well in any way, just don't take it, right?
Thanks.
Nobody has any questions?
So, Farooq, I think that was a fantastic talk. Thank you. My question is, a bit of pushback that you might receive is, what do you do with the Asian or South Asian individual that's, metabolically unhealthy, of a normal BMI, where, maybe you're hearing from the cardiologist, nephrologist, they want them to be on this, they have, CVD, how would you approach it, or would you maybe put them on insulin in order to put them on this medication to potentially derive some of the benefits? I guess the question is the overall approach you would have for that kind of a patient.
Well, I mean, I have a low threshold of younger people being like, I start young people on SGLT2 inhibitor because sometimes it's not just the BMI, because I've seen thin people, but it's rare though, right? I mean, they have small bellies, but they have severe resistance to insulin. They may not be insulin deficient, right? And I always tell people that if you look at the glucose profile of a patient, you can tell if the patient is insulin deficient or not, actually. It's very simple. And this comes with, experience. I'm a very old guy now, right? So I've seen a lot of patients. So if you see an early type 2 diabetes, when they have insulin resistance, what they do is they don't make enough uh, basal insulin in a fasting state. So early type 2 diabetes will have high fasting blood glucose, right? Okay. Now, when you see a 75 or 80-year-old man with type 2 diabetes who has diabetes for 15, 20 years, you will see this glucose profile. Morning is 5 and at lunch is 22, right? It gives you an information that, listen, this guy is insulin deficient. So good fasting blood sugars, but very high postprandial blood sugars is insulin deficiency. And then you see early type 2 diabetes or patients who may not be insulin deficient, even if they look thin, they have high fasting blood sugars from increased hepatic glucose output, not producing enough basal insulin at night, but as they eat, their sugars get better. And this is the profile that I usually look at most commonly when I consider, right, in those Asian group. And to be honest, I have a low threshold too. In young people, I can justify. I have a 55-year-old, if he has a problem, I'll put them on, right? It's not a problem. But I'm not gonna, you know, I'm not gonna behave like a trained monkey putting a 75-year-old because he has diabetes and then he has a heart disease. You know, like I've seen 92-year-old on SGLT2 inhibitor, and I asked myself, what are we going to prevent in this patient, right? She's 92 years old. She's more likely to have side effects from those drugs, right? So it's very relevant actually that every patient is different, right? Every patient is different. You cannot generalize treatment. And then you have these studies where you have young people, right? I mean, studies, look at our population, right? 75, 80, 85, 90-year-old. And then you have in studies 55-year-old, right? So those patients completely different. Anybody has any?
There is someone, question in the chat.
Yes.
Patient with no history of diabetes on Jardiance for heart failure, had episode of gastroenteritis and developed ketosis. I assume it is starvation ketosis only.
No. So as I said, actually, to be honest, like I have seen young people actually, as I said, I have one patient actually, twice this happened in emergency, that there's a patient who was following low carb diet, right? So you have starvation ketosis. Starvation ketosis would not cause, like a true DKA. And of course, when you say diabetic ketoacidosis, right, you're talking about patients who have diabetes and ketoacidosis, right? So you can have starvation ketosis, which can be made really worse with, in my opinion, SGLT2 inhibitor, even if the patient is not a diabetic, right? They become extremely acidotic because now you have further increase in glucagon levels and further ketone formation, right? So I would say, yeah, it's starvation ketosis, but it's probably the worst starvation ketosis, right? A person can have, right? So definitely never think that the drugs have an effect, not just on insulin or in diabetics, right? It has an effect, it has lipolytic effect. And I give you an example. You ever see patients on SGLT2 inhibitors say that they're extremely hungry? You know why? When your sugars go low, you have a very brisk rise in your glucagon levels, which can make you feel hungry. So people on SGLT2 inhibitors actually feel hungry because their glucagon levels are very high. So I always tell patients, it's from a hormone that this drug is driving up, right? So definitely, in my opinion, that even a person who is not a diabetic, if they follow this extreme low carb diet, they could become extremely sick. They become extremely sick with metabolic acidosis with these drugs. Because in a normal person, you would inhibit glucagon, right? In a normal person, you would inhibit glucagon with intra-islet basal insulin, right? But if you have a drug which actually lowers insulin, there may be a direct effect of these drugs in normal people inhibiting insulin secretion, as in human islets, right? I showed. And then on top of that, you have an effect on glucagon, right? So I personally think that even patients who may not be diabetics may be at risk, right? Actually, to be honest, like one day, you'll be surprised actually. A couple of months ago, acute care in Centenary has 5 beds, right? So one day on the weekend, there were 3 beds with DKA. No, I would not give IV insulin. I mean, there's no indication. You can give IV insulin. That's a very interesting question, actually. I mean, I know the answer that you can give intravenous insulin in other conditions. For example, once I have a patient who came in with a triglyceride levels of 125, right? I mean, he was extremely sick. So I put him in and give him dextrose with insulin. We give insulin and dextrose in patients with hyperkalemia too. So the question is that there's not enough cases or there are not enough studies done to see if it would work in those patients. And similarly, if you see, as I said, like you can give octreotide and improve DKA. There's many studies done with octreotide inhibiting glucagon and improving DKA. There's mixed results because there's not enough patients to you know, to do studies on, right? Yeah. So yeah, I guess you can, I guess if you can. It's a very okay. So here's a question I have. So DKA, and this is another point, right? I mean, DKA is not defined by hyperglycemia. So you have to rule out all other causes of A9 gap acidosis. And then you can say it could be ketoacidosis related to diabetes, right? For example, like you can have a normal pH in patients with diabetic ketoacidosis when they are vomiting, right? So in my opinion, I think acidosis where you have unmeasured A9s are from ketones. So can you fix ketones with insulin drip? Probably can actually, right? So would you use it? I don't know. I mean, I've never seen a case, right? I have never seen a case. It's a very interesting question, actually. Non-diabetic with um, severe metabolic acidosis. Any other question?
I think if that's it for the questions, thanks again so much, Farouk. This was a very interesting talk, and I think really relevant to the patients that we're seeing coming into all three sites. So really appreciate it.
All right. Thank you. Thank you.